Hello everyone, my name is Ana-Maria Bucalau. I'm a gastroenterologist and a digestive oncologist in Erasmus Hospital in Brussels, Belgium. As a part of the ESDO LearningBytes initiative, I shall give you today an update and some key points on the management of neurological toxicities of immunotherapy. Immune checkpoint inhibitors have transformed the treatment landscape of numerous cancers, producing durable responses in a substantial fraction of patients. Neurological toxicities have emerged as clinically relevant complications of immune therapy, and different types of autoimmune-like inflammatory events have been described, such as peripheral neuropathy, going as far as Guillain-Barré syndrome, or central neurological toxicities such as encephalitis, aseptic meningitis, or Press syndrome. However, these are just a few of the possible manifestations. Neurological adverse events are uncommon, with an overall incidence of 4% with anti-CTLA-4 antibodies, up to 6% with anti-PD-1 antibodies, and 12% with combination therapy. The precise mechanisms involved in immune-related adverse events are not completely known. Neurological events generally occur within the first 3 months after starting therapy. However, myasthenia gravis may have more rapid onset than other events. In a pharmacovigilance study published in 2019, myasthenia gravis also had the highest fatality rates. When associated with both myocarditis and myositis, it had the highest death rate. Neuromuscular junction dysfunction, such as myasthenia gravis, was reported more in patients treated with anti-PD-1 PD-L1 compared with anti-CTLA-4. Non-infectious encephalitis was reported more with anti-PD-1, anti-PD-L1 than with CTLA-4 and with combination therapy compared with monotherapy. By contrast, Guillain-Barré syndrome and non-infectious meningitis were less frequently reported with anti-PD-1 PD-L1 compared with anti-CTLA-4 monotherapy and were more frequently associated with combination therapy. In a single-center retrospective cohort study conducted from September 2014 to May 2016, patients with development of neurological symptoms within 12 months of anti-PD-1 therapy were included. 347 patients were treated with anti-PD-1 monoclonal antibodies, pembrolizumab or nivolumab. 2.9 patients presented subacute onset of neurological symptoms. This occurred after a median of 5.5 cycles. The time to maximum symptom severity varied from 1 day to more than 3 months. Treatment with anti-PD-1 antibodies was discontinued in 7 patients. Treatment included corticosteroids, intravenous immunoglobulin, and plasma exchange. Peripheral neuropathy can go from mild to severe, and workup and evaluation include neurological examination, autoimmune anamnesis, alcohol history, medication, diabetic screening, and complete blood analysis. MRI of the brain or spine, lumbar puncture to exclude tumor invasion, EMG for lower motor neuron or sensitive change, and in severe cases, you can consider pulmonary and diaphragm function. In case of mild onset, treatment can be put on hold and symptoms monitored for a week. If you continue treatment, monitor very closely for any symptom progression. If symptoms are moderate, treatment must be held, but it can be resumed once symptoms get better. Treatment include prednisone 0.5 to 1 mg per kilo per day, especially if progressing from mild onset. Pain medication include gabapentin, pregabalin, or duloxetine. However, if symptoms are severe, the treatment must be permanently discontinued, the patient admitted, and neurology consultation is mandatory. Treatment is methylprednisolone 2 to 4 mg per kilo per day and may proceed as per Guillain-Barré syndrome management. Patients with limited self-care, weakness, limited walking, any dysphagia, facial weakness, respiratory muscle weakness, or rapidly progressive symptoms should be admitted into an inpatient care unit with capability of rapid transfer to ICU level monitoring. Corticosteroids are usually not recommended for idiopathic Guillain-Barré syndrome. However, in immune therapy-related forms, a trial is reasonable, followed by slow dose reduction. Pulse steroid dosing with methylprednisolone 1 gram daily for 5 days may also be considered for severe forms along with immunoglobulins or plasmapheresis. After pulse steroids, a slow reduction is necessary over 4 to 6 weeks. If myasthenia gravis is suspected, the patient should undergo a full blood workup. While the presence of antibodies is confirmatory, the absence of antibodies does not rule out the syndrome. A special attention should be given to the medications with risk of worsening the symptoms, like beta blockers, IV magnesium, fluoroquinolones, aminoglycosides, and macrolide antibiotics. Other investigations include pulmonary function assessment, inflammatory markers, cardiac markers, MRI of the brain and/or of the spine, electrodiagnostic studies, and paraneoplastic workup. Treatment consists of pyridostigmine, corticosteroids, immunoglobulins over 5 days or plasmapheresis for 5 days. Rituximab should be considered if the patient is refractory to immunoglobulins or plasmapheresis, and the patients should undergo frequent pulmonary assessment and daily neurological review. Central neurological toxicity can manifest as encephalitis with coma, acute neurological deficit, epilepsy, confusion, and might be rapidly worsening. Neurologic consultation is mandatory. Ophthalmic or neuro-ophthalmic evaluation is necessary if ocular involvement is present. The patient should undergo MRI with contrast of the brain, orbit, cervical and thoracic spine cord, lumbar puncture, serum studies, evaluation for urinary retention and constipation, EEG to evaluate for subclinical seizures. The patient should be treated with a combination of methylprednisolone 1 to 2 milligrams per kilo, acyclovir until PCR for viral infections is negative, antibiotics until negative cultures, and ICU admission should be considered and cases should be discussed with a neurologist. Another presentation of central neurological toxicities is aseptic meningitis. It can be mild with headache, fever, meningeal symptoms, or severe with seizures, paralysis, or impaired consciousness. Workup should include brain MRI, lumbar puncture, infectious workup, blood analysis for lactate, and open pressure measurement done during lumbar puncture. When severe, the treatment should be suspended. The patient should have neurological consultation and infectious causes should be excluded before start of steroids. The patient should be transferred to ICU for symptom management and exclusion of other causes. High-dose prednisone should be administered. If no response is seen within a week, second-line immune suppressants should be considered. So to conclude with some take-home messages, neurological immune-related adverse events are rare, but be aware because time of onset is unpredictable and evolution may be rapidly life-threatening. The neurologist is your new best friend, extensive workup is frequently required, and treatment is usually based on corticosteroids, immunoglobulins, plasmapheresis, and non-opioid management of neuropathic pain. If you need help in managing immune-related adverse events, do not despair. The ESMO and ASCO guidelines are just a click away. Also there to help is the Belgian Immunomanager diagnostic and treatment algorithm that makes it easier to deal with different types of immune-related adverse events. Thank you very much for your attention. Keep calm and fight cancer.